it going? Good? Not bad? Good?
¿Ah? Lo vi, sí, 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 sí. Pero yo creo que él fue de educación, al taller de educación.
Idalí, yo no sé si tú pensabas hacer eso, pero sería bueno saber en qué settings trabajan.
Sí, 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 sí. Vamos a empezar primero.
I was on the panel in New York, and it was like one of the, like, we didn't want to leave the room. So they had to, like, pull us up. We were having great conversation.
Okay, so I think maybe we should wait because I don't want to make us late. Yeah, I think we should wait, and I suspect that there will be a few people coming in as soon as they get their coffee. There was a long line waiting for the coffee, but I think we do need to finish by 12:30. Gracias, Pablo. Nos vemos en el panel tuyo de la tarde.
No, ahora.
Really?
Ay.
The media. Ah, ma.
Paralelo. Son paralelos.
Paralelos, okay. So anyway, my name is Maria Idalí Torres. I'm the director of the Mauricio Gastón Institute for Latino Community Development and Public Policy at the University of Massachusetts, Boston. And I'm a long-time resident of Springfield and a community health worker or promotora. And I am responsible for trying to keep us on track with our discussion about health disparities. If you look at your program, the goal of this session is to examine health disparities, especially in key areas such as diabetes and its relationship to nutrition, asthma, mental health policies, and effective preventive community strategies. Of special interest are the enrollment of Puerto Ricans in health plans, especially Medicaid and Medicare, and I think that this is related to what Dennis Rivera was saying about the disparities that exist in Medicaid between the states and the territories of United States. So what I would like to do is first get a sense of who we are. I'm going to introduce the panelists, and then I am going to come back and say a few words about what health disparities are. And I think for us to engage in a meaningful conversation, it will be very good to know who you are, what agency you work with, what make you come to this session and not to economic development or to education. So there's also, I wanted to let you know that there is a tape recorder.
This is the health.
Yes, there is a tape recorder here that is going to capture our discussion with the idea that it will be transcribed and served for the future, to be used for planning of other conferences, as well as maybe the type of work that we all decide that it will be important to do in this community. Here in the table we have three colleagues who have a lot of experience addressing different health disparities in the Puerto Rican communities. Starting with Dr. Milagros Rosal, who is a professor at the School of Medicine in Worcester, and a person who has implemented many different, or tested many different interventions related to diabetes and other mental health and other interesting topics. The next is Dr. Margarita O'Neill, who has been for the last 10 years working at Union College and University in Brattleboro, Vermont, training the new generation of psychologists. And she also lives in Western Mass and have worked in some of the mental health settings and organizations in Western Mass. And we have Sofia Segura Perez, who is coming from the Hispanic Health Council. She's the Associate Director of the Nutrition and Education Unit. And she has a lot of experience working with community nutrition programs, including promotoras in Hartford. And she is going to talk about some of the best practices that they have implemented in Hartford with a degree of success that may be reproduced in other Puerto Rican communities. And the conversation that we want to have, I think, is not about statistics, because we can all get those from the internet, but more about what have been some of the strategies that have worked to address the health disparities in the Puerto Rican communities, and how can we share that body of knowledge to adapt them to different Puerto Rican communities in different parts of New England, as well as in Puerto Rico. So I am going to now go around and ask you to introduce yourselves and tell us what did you do and what is your interest in health. So starting here.
Hi, my name is Grace Sands, and I'm a community health worker. I work with people with stress reduction and smoking cessation.
Okay, great. And where do you work?
I work for River Valley, but I'm part of the Healthy Holyoke program, which is a collaboration between Holyoke Health Center and Holyoke Medical Center.
Okay, great.
The city of Holyoke.
Okay, okay. I think I'm gonna. Hola, ¿cómo estás? Entonces, maybe that may be important so that we don't have a lot of interruption. Next.
Maria Valle, I work with seniors.
Okay. Bienvenida.
My name is Laura Roro. I'm a clinical psychology in the Behavioral Health Network in Springfield. And I like to know more information about how the health disparities and the health, the ideas of how I can help my clients and my patients.
Okay.
My name is Margarita, and I'm a medical anthropologist. I work at Holyoke Community College, and I'm currently working on a maternal mental health project with an organization based out of Hadley, but the project is on women of color's health disparities, health issues here in Hampton County.
Okay, great.
My name is Luis Carrasquillo. I'm a student at UMass. Basically interested in health disparities among Latino communities, especially Puerto Ricans compared to other Latinos, and also epigenetics.
Okay, great.
My name is Dennis Garcia. I'm a community health worker for Holyoke Health Center.
My name is Gabriel Aquino. I'm an associate professor and chair of the sociology department at Westfield State. So I teach a lot of nurses through the classes I teach, so just here to pick up on that.
My name is Julia Rojas, and I'm involved with the senior Holyoke, and I'm interested in Alzheimer's and diabetes because of personal reasons.
My name is Norma Fuentes, and I'm a student at UMass Boston, anthropology student. Someday I'd like to go on and study health disparities with an MPH.
My name is Noemia Ginzoli, and I work at the Department of Social Assistance, and I'm interested in this subject because I work with many people that have many issues.
Okay.
I'm Jacqueline Rosario. I'm a registered nurse, and I work for the Holyoke Health Center. I'm also part of the Prevention and Wellness Trust Fund grant, which is where Dee and Dennis we're all collaborate and work together, which is part of Healthy Holyoke at the Holyoke Health Center.
Great.
Hello, my name is Janera Vega. I'm a psychologist at Behavioral Health Network in Springfield. Our clinic is completely bilingual, and mostly we have Puerto Rican clients. So I'm interested in seeing what you all have to say about the disparities in mental health with our population.
Hi, Dave.
Idalí. And Jay Bryness, I'm the CEO at the Holyoke Health Center.
Next one, I'm the Ward 2 City Councilor here for the City of Holyoke. But I'm an openly LGBT and HIV positive male, and I do a lot of regional and nationwide advocacy and outreach for HIV/AIDS health disparities.
Yep.
I'm Yolanda Negron, officially retired now.
Obviously have had a lot of experience dealing with healthcare. And I was born in 1963, and back in 1963, none of the things that exist now, especially for Latino population, existed then. My mother was a young Puerto Rican mom who barely spoke English, but she still managed to really advocate for me. And then several years ago, the roles were reversed. When my mother, due to diabetes, eventually, and also she ended up with dementia, and that's when I discovered there's not a lot of information for families who have family members who have dementia, who have Alzheimer's. And so I found myself kind of like feeling almost like alone or so forth. Luckily, because I'm fully bilingual, I was able to go on the internet and so forth, but many families don't have that. And so I'm interested in advocating for families with loved ones who are dealing with dementia and Alzheimer's.
Hello everyone, my name is Brenda Reyes. I am the parent educator at Planned Parenthood. I teach a curriculum that is called Let's Be Honest, or Seamos Honestos. This curriculum is to give parents different strategies and techniques on how to talk to their kids about sex and sexuality. One of my reasons to be here this morning is because I reach so many people in the course of every day, so I would love to learn about this issue so I can also educate my community and help them help themselves.
Hi everyone, my name is Jasmine Garcia. I'm a psychologist student at UMass Boston. I'm currently working at the Gastón Institute, and I just wanted to learn more a little bit about the health issues from the Puerto Rican population.
Hi, my name is Shilda, and I'm a medical anthropologist. I'm a postdoctoral fellow at the UMass Medical Center in Worcester, working with Dr. Wazal. And for my dissertation, for my degree, I lived in Puerto Rico for about a year. I was looking at diabetes, depression, and obesity, and at Stockless, I was looking at the relationship between health and the economic and political crises.
Yeah. I want to know that there are 3 medical anthropologists in the room. So far, right?
Community health workers.
Yeah. And lots of very good.
And
yes.
community health
and
workers.
lots of community health workers. This is great. Great combination.
My name is Mariana Valencia. I'm a student in UMass Boston. I'm a biology major, and I'm just interested in the healthcare.
Hi, my name is Kayla Cruz. I'm representing Abuente from Williamsburg, and I'm just interested in health. I find it's important to take care of yourself.
Good morning. My name is Merida Rua. I'm a professor of Latina and Latino Studies at Williams College.
Wow.
I teach urban studies, growing what it means to grow up and grow older in urban communities, and my new project is on aging and urban life, focusing on Puerto Ricans and other Latinos.
Great.
My name is Luisa Ponte Pares. I'm a retired UMass professor. But I was wondering, because I think that there are 2 concerns which obviously the panel cannot deal with it, is the aging Puerto Rican population, and a separate issue but very important, HIV. And I think that both are alongside.
Yep, that's good.
All people are very important because we fail to realize that many of people's dream of going back is not happening.
Right.
So we have a lot of people stuck here, including one.
Yeah, I agree.
Hi, my name is Jenna Machad. I'm a prospective nursing student at UMass Boston, and I guess I just want to know a lot more about the health, sorry, I'm so nervous. The healthcare disparities in Puerto Rico. Living over here, you don't get as much information as you should, so everyone coming together and speaking about it really, I'm sorry, I'm so bad at this.
That's okay. That's okay. We are in familia aquí.
nada, que quiero saber más de la comunidad latina y what better place to be than here.
Agree.
My name is Nicole Ocasio. I'm a biology student at UMass Boston. And I'm here to, I actually work with Idalí in the Gastón Institute as well. I'm also here to learn a little bit more about the health disparities.
My name is Luis Falcon, and I'm the Dean of the College of Fine Arts, Humanities, and Social Sciences at the University of Massachusetts at Lowell. And also a professor of sociology, and also a principal investigator at the Center for Puerto Rican Health Disparities, also at the University of Massachusetts at Lowell. And I work on aging, gerontology, and health disparities.
Hi, my name is Melinda Gonzalez. I'm representing El Puente in Brooklyn, New York.
Oh, wow.
Yeah. And community organizing, education, all of these intersections. But what drew me to this particular is that I also do bomba. I have a bomba ensemble, and we work with young people, we work with seniors as well. And I'm looking at how bomba can be a source of healing.
Yep.
And remembering folks who are suffering from dementia and Alzheimer's as well. We've seen incredible, really incredible, and very interesting results of when we go into senior centers, but also integrating students and young people as well. So our ensemble is intergenerational for that reason.
Hi, good morning. My name is Josimar Matei, and I work as an assistant professor of nutrition in the Harvard School of Public Health. Also 2-hour commute here, but I'm very excited to be here today. And my work has been on lifestyle research as well as community work and community programs on lifestyle factors for chronic diseases, a lot of obesity, cardiovascular disease, and heart diseases. And although I work with all Latinos, as a proud Puerto Rican, my heart is working with Puerto Rican communities, both here as well as in Puerto Rico.
Great.
Good morning, my name is Jose Montero. I'm Director for Community and Family Engagement for the Department of Children and Families. And I'm here because I understand that when you have healthy families, you see less cases of child abuse and maltreatment.
Yes.
So I'm interested in hearing what they have to say.
Good morning, my name is Jasmine Rubey. I'm with Southbridge Community Connections.
Great.
We are actually funded and under Jose. Our physical partner is Harrington Hospital in Southbridge. And the
Great.
reason why we're here is because we have a couple of healthcare, community partnership with healthcare providers. So we just want to be knowledgeable of the resources and services.
Excuse me, I'm Jitsa Vasquez. I'm Director of Southbridge Community Connections, funded by DCF. So kind of what Betty does here, we do that in Southbridge. Harrington is our fiscal agent, so we were torn whether the educational piece, because our students wanted the receivership salary, and the health piece. So we just want to see if we can probably get here and sneak off over there and get as much as we can.
But I want to say this is great to have representation from Southbridge, because Southbridge is one of those long, well-established Puerto Rican communities that we don't think about it because the city is so small. But I was looking at 40% at the data, so 40% of your students in public schools are Puerto Ricans. Yes, mainly
mainly Puerto Rican, and it's sad because they just, now that we went on the receivership, they just assigned an ESL person, which we didn't have.
So great.
So we're going through a lot of issues. It also has the highest cases of families involved with the Department of Children and Families, and it all goes back to, you know, the basic needs, health, food, shelter, all of that. So we have a lot of work.
So we have here people from Brooklyn to Southbridge, up the hill to Lowell, and down to Western Mass. Thank you so much. So many different interests, so many different topics. So what I thought is I will start by saying a few words about what a health disparity is, and then to begin the conversation so that we all are in the same place to begin the conversation. So I have a few notes. telephone that defined health disparity as a difference that is closely linked with social, economic, and environmental disadvantage. Health disparities adversely affect groups like the Puerto Ricans who have systematically experienced greater barriers or obstacles to health. As we know and we heard this morning, Puerto Ricans in both lados del charco, right? We experience disparities due to colonialism, discrimination, socioeconomic status, gender, age, mental and physical disability, sexual orientations or gender identity, geographical location of our neighborhoods, and we also saw this morning the impact of the environment in some of the communities in Puerto Rico and other characteristics of the places where we live and work and play. And our goal, I think the goal for everybody from the point of view of public health is to achieve equity, health equity. And health equity begins, I think, with valuing every person equally, and to look at what are the conditions in which we live that make us have a bad health. And we know that for Puerto Ricans, that is tied to institutional, well, colonialism first, institutional racism, discrimination, historical, and socio-political and economic, political economy, also conditions that have been created by the situation of Puerto Rico being a territory of the United States. We heard about the disparities on Medicare reimbursement and how that is impact the health in Puerto Rico. Even though the Affordable Care Act has have improved the access to health insurance coverage in Puerto Rico, we know that that expires this year. And if there is no continuation of that influx of support, economic support for Medicaid, the impact will be devastating as many people will be withdrawn from the Medicaid program, which covers, I think Dennis said 46% of the people in the island. The truth is that in both lados del charco, we experience the same disparities. We are dying from cancer and diabetes and strokes and other health diseases and injuries caused by accidents. We tend to find out, for example, that cancer later on in very severe stages, and therefore with a very poor prognosis of living a better quality of life. We know that many Puerto Ricans with diabetes have a very difficult time trying to manage their conditions. We also know that we have a high rate of substance abuse, and including alcohol, that also contributes to both the quality of life and the mortality rates due to some of the health problems or conditions like cirrhosis of the cancer, liver cancer. Cervical cancer also is very high. Puerto Rican women have the highest rate of cervical cancer of all the Latino groups. Asthma. When it comes to asthma, one of every for Puerto Ricans has been diagnosed at least at some point in their life with asthma. And the interesting thing about asthma is that it's a very poorly understood disease. And it has sort of not gotten a lot of attention for research and for trying to better understand what can be done to prevent and manage asthma. And in part it's because the people who experience asthma are at a very low level of the economic ladder, as we know. We have high rates of infant mortality and low birth weight. And we also continue to experience delay. Even when the Affordable Care Act have improved insurance coverage, that has not improved access to health services. We continue to see delays in services provided by specialists, as well as delays in other types of services that require that we should not experience those disparities and the barriers to access when health insurance. But I want to say that in many Puerto Rican communities, having health insurance is not enough to eliminate the barriers for access. So what we're hoping today is the statistics. I mean, I think, like I said, we all know them, and some of them have. Some of us have lived them, and I like to have the panelists talk about what they have been doing to try to address those health disparities in different communities, and to also invite you to join in a conversation about how can together we can begin to create a movement towards promoting health equity in Puerto Rican communities in Massachusetts, but also in other parts of New England. So I'm going to start with Dr. Rosal. I'm going to ask her to talk about her work in Lawrence, where she has for many, many years been doing work on diabetes, and done from everything from clinical interventions to very community-based interventions, including fotonovelas about diabetes, and to talk to you about some of the things that you have observed and some of the strategies that have worked and perhaps can be reproduced in other parts of New England.
Okay. Well, good morning, everybody. It's great to have a lot of familiar faces in the room. So I look at the disparities from the research lens, and I believe that research can provide very helpful tools because data can help modify policy and can help make other changes in the circumstances that people live. So a lot of my work has been with Latinos and with Puerto Ricans in particular. I have conducted my research in Lawrence and in Springfield as well. The focus has been health behavior change. So I have worked with dietary changes, physical activity, specific tasks involved in diabetes management, like self-testing blood glucose levels and so on. I have focused in the areas of diabetes prevention, obesity prevention and management, gestational weight gain, postpartum weight loss, as well as mental health issues and utilization. I just have 5 minutes, right? Is that what it is?
Yeah.
So
that's right.
In terms of my current work in Lawrence, it actually emerged from the previous work. It's been a research program that started with a diabetes prevention, the translation of a diabetes prevention intervention that was published in 2002 that showed that diabetes can be prevented or its onset can be delayed if there are interventions to facilitate lifestyle changes that produce a weight loss of about 7%. So these, what we call efficacy studies, what they do is they pour tons of money and resources into helping people make changes so that the hypothesis of the study can be tested. In this case, the hypothesis was that with a weight loss of 7%, you can prevent the onset of diabetes. So the study was very successful. In fact, it was stopped ahead of time because the findings were so overwhelmingly positive for the fact that weight loss, in fact, prevents or delays the onset of diabetes. So the next question came about, how do you translate an intervention like that to populations that are at very high risk, that are either genetically sensitive or that have lifestyles or circumstances in their lives that contribute to weight gain. And so we focused on Latinos and did a modification of the original intervention, which was a lot less time intensive from the perspective of the participant as well as the perspective of the providers. So in the original diabetes prevention program, it was an individual intervention. It was personalized coaching that went on for 2.5 years, and there were resources for gym memberships, shoes, and motivational campaigns, a lot of all the bells and whistles of these efficacious interventions. In a community like Lawrence, the resources are very limited, so we did the intervention in a group as opposed to individual. We focus on very practical matters like cooking together, modifying ethnic recipes that recipes that people like, rather than asking them to eat something different. Working with the families, seeking support from the families, engaging the families in the intervention. Trying to address some of the myths of the population that have to do with diabetes is in my blood. Everybody in my family has it, so I'll get it someday. And addressing ways of thinking about food. For example, we saw food in the pilot work we had done. We saw food as a way of showing affection, which is, I think, is common to many cultures, not just the Puerto Rican or the Latino culture. And we, yes. So we developed a, using narrative, in this case it was the soap opera that Idalí described. We developed a video soap opera that sort of used just about every topic that we have seen in terms of challenges to change, to people changing their behaviors, and had the characters be in situations where they would have to talk about it. So it wasn't like the characters were perfect and now we're showing this soap opera for people to see, to model somebody who has a perfect lifestyle. It wasn't anything like that. It was more like, let's say the main character was had her daughter in town without a job and was trying to help her, and so she would cook these Puerto Rican meals, very heavy in fats and salt and sugar and fried and all of that stuff. And as a way of showing, and would buy her donuts as a way of showing her affection, treating her, getting her to, getting her spirits up. And so she would go with her daughter to her own doctor's appointments, and so there would be a conversation from the doctor, like, how is your diet? The daughter would say, oh, my mom has been buying donuts for me, but she's the one that eats them. And then the doctor would say, well, help me understand, because you've told me you are very concerned about your daughter's health. So can you help me understand how that all goes? And so it was just like bringing the topics up, and then in the intervention groups, people would react to that. And then, rather than a provider saying, are you eating donuts? Or it would be more like, what do you think about that? And people could identify and then say, oh, that's me, I do that, rather than being questioned or putting against the corner. So the intervention was very cognitive as well as very behavioral in terms of the tools offered with the cooking classes and all of that. And what we showed was that, in fact, people do lose weight. It's modest weight loss because it's a much more simplified intervention. But we observed exactly the same changes in hemoglobin A1C, which is the measure of blood glucose in the participants. Exactly the same, a little bit better even than in the original diabetes prevention program. So not only did we learn, well, these interventions do work, but we also learned that perhaps for people who are very sensitive to developing diabetes because of weight gain, just a little bit of weight loss can go a long way. So maybe they don't have to lose the 15 pounds that the participants in the original DPP had lost. That, just 2-3 pounds can actually do a lot for them. So, I think I went over the 5 minutes, but that's just in a nutshell, just one of the pieces of the work that I do. I do a lot of community work also, helping the communities to develop more awareness about research, and we call that research literacy. It's not a term I really like to use, but it's really research knowledge. Like how can, what is research? Why should people consider participating in research? And empowering people to have information to make an informed decision.
Okay. Any pressing questions for Dr. Rosal before we move on? Okay, great. So, Dr. Maggie? Okay, yes?
Do you have those videos available?
Yes, they are available. Yeah. I can give you mine.
Good. So then we will have the opportunity for people to get addresses, or we will find a way to connect. I am going to actually pass a piece of paper so that you can sign and put your address and email address, so maybe we can communicate with each other in this way. So our next, yeah.
Yeah, I would like to know how the Latino community respond to this program that you are engaging them in, and did you feel that you have to really push them to come into the door for these programs, or they're just willingly able to accept the offer?
Yeah, so this program, differently than the efficacy program, the original one, where people were recruited, I think there were 2,000 people screened to recruit one. Here we went to the people in the health centers that were at risk and that may or may not be interested in losing weight, but the program was to engage them in this, because it's two very different populations. One very highly motivated, which you have to recruit to be able to test the study hypothesis. But when you're doing a translational study to bring the knowledge and the benefit to the community, you're dealing with a whole different situation. So we provided transportation and we provided childcare, because some of these people had children, other ones had grandchildren that, as you know, a lot of grandparents taking care of grandchildren. So we provided that to facilitate participation. In addition to that, although people know this is a weekly program and then a monthly program, you have to make phone calls the night before and sometimes the morning before to remind them or to check, did they have any issue, did transportation work or not. So it's time intensive in that sense, but not in the sense of the cost of the actual intervention. Yeah.
Margarita.
Buenos días. Casi buenas tardes, son las 12 ya. mi trabajo ha sido en el área de salud mental, especialmente con niños y familias, por muchos años en Worcester y en Southbridge. Yo conseguí que el Departamento de Salud Mental abriera unas oficinas en Southbridge en los 80, porque esa es una parte de, yo quería hablar un poquito de la cuestión del health disparities en términos de acceso. I'm sorry, I switched languages here. In terms of access, that they're not, in the area of mental health, they're not, and I think in all areas of health, there are not enough mental health providers who are bilingual. Or who are knowledgeable about Latino cultures and Puerto Rican culture, and that continues to be the case, and there are many, many reasons for that. But in the area of mental health, where it's not the same as going with a physical health problem. Psychologists and mental health providers, it's language that you use, and so the language issue becomes really paramount in terms of being able to provide mental health services. And so I'll talk a little bit about some of the strategies that we used to try to maximize the utilization. I think that some of the problems in terms of access are due to the system and what's available, but and distance was one. Like we would get referrals in Worcester from Southbridge, but there was no public transportation from Southbridge to Worcester. Well, and it was the same thing. Like we opened up also an office in Fitchburg because it was the same. They would refer to us. We were the only game in town at the Worcester's Guidance Center, and people would come to the first meeting because they would get like the DCF worker to bring them or something like that, but then what? So, sometimes that can be an issue. I think that some of the other issues, and I think that Idalí alluded about that, is that people tend to come when the condition that they have is much more serious than in the general population. And I think that in terms of mental health issues, we are a more tolerant culture. So things that other cultures may immediately see as a problem of either, lack of intelligence in a child or, a behavioral problem or psychological problem, often get interpreted as, oh, he's just like that, as idiosyncrasies, as a personality issue. So we would have like kids who would show up at a much later age when it was clear that they had, for example, an autistic spectrum disorder or any, developmental disability or something like that. They came later because the family was a lot more tolerant of idiosyncratic, what they saw as idiosyncratic behaviors. So, there are many, many reasons why people, stigma is another one. I don't want them to think that I'm loco or something like that, so people don't avail themselves to the services. And sometimes in issues, I remember when we first started talking about, sexual abuse in the early 80s, it was also, people wouldn't report to DCF, for example, because they didn't want people to associate child abuse or sexual abuse at that time with them being Puerto Rican. So there was also like an issue of honor and an issue of not like bad-mouthing somebody who was Puerto Rican by reporting the abuse. So again, problems tended to come at a later date. In terms of addressing, the waiting lists, also, there's incredible waiting lists for services because there are not enough professionals. And I think the not enough professionals also has to do with the cost of education, cost of graduate Graduate school, if you want to be a psychologist, it's at least 5 years that you have to be in school. There aren't very many programs that have enough access, and actually the American Psychological Association is behind other professions in terms of accrediting programs that provide more hybrid models of online that's still not seen as acceptable in the psychology world. So there aren't very many people who can take off 5 years of their lives and go full-time to get a degree. And there's not enough financial aid at the graduate level. So those are some barriers that we have in terms of people being able to get the degrees to provide the services, even if they have the talent and the interest. So sometimes you need to think about, what can you do in terms of doing sort of like broader systems approaches, like you're doing the groups for the diabetes. In Worcester, we had a mental health community education program on the radio, for example, and we had it was once a week, and we had a call-in show. And for example, at in August, we would have, so how do you prepare your child for the first day of school? How do you establish relationships with your teacher? And so that month it was something that was relevant. So other times was, how do you deal with sexual abuse, for example, or any topic that had to do with mental health in the community. The show was in Spanish. People could call in their questions. So you were delivering some mental health community education to people who perhaps weren't going to go to the mental health center, or were on a waiting list, or maybe it would elicit their participation in the mental health services. We also, a little bit of, you can do clinical research, not of your clinical population. So we would very carefully look at our referrals and really look at who were we seeing, and what were the common problems that the people were presenting. And for example, one of the things that happened was even though it was a child agency in Worcester, we would see that a lot of the families were experiencing domestic violence, for example. So we had a lot of moms who were being battered, a lot of moms who were sort of isolated in their own communities. So we started thinking, so what's we couldn't assign every mom an individual therapist, but we hired a parent aide. And so she would bring these people together in groups, because we felt like, how can a mother who's being abused, who's isolated, who's not getting any nurturance for herself, be a good parent and nurture their child and not abuse their child? So we saw it as all connected. So we were providing some nurturance to the moms, some sense of connection. This woman that we hired was incredible, and in the summer they would go to parks together. They would do activities together. So it was like connecting them to a community that they had lost, and that they may be the natural thing in Puerto Rico, but they weren't finding it here. So how can we build those connections? So it's indirect ways of impacting, depression, isolation, mental health problems and anxiety. And they also share strategies, that they could teach each other about it. So the other thing that we saw was we had a lot of families, a lot of them that were placed in foster care, and that sibling groups that were split up in different foster homes. And so we were saying, again, we can't give 5 kids individual therapy right now because we have a waiting list, but what about doing sibling therapy? And so we developed this sibling therapy approach, which actually accomplished many different things at the same time. We were able to treat the abuse as a sibling group. We were able to, those kids didn't see each other. So now they had, every week, they came together. So looking at your caseload and looking at, so what are common things that are happening? And are there non-traditional ways of approaching them, that maybe you can't immediately give them each one a therapist, but how can you do that? And then one other thing I'll mention quickly is that we talked about when we met about what we were going to talk about, and it's like, I think one thing that gets forgotten is the professionals and self-care and preparation, and especially when we're bringing people from Puerto Rico now who are coming here for jobs in the area of mental health, is that they're coming to a very, very different system of care, and they have different levels of autonomy. They're going to require a lot more documentation in English, in writing, which is a big transition, no matter how bilingual you are. And they're going to be, one of the things that we forget, that there's a parallel process for those people. They have also are experiencing dislocation. Their children are experiencing a transition to schools here. They are probably, the salary may sound good, but what that salary buys you here is not what you expected, and it's not what it would buy you in Puerto Rico. So people are often, professionals are living in economic circumstances that are less than they're accustomed to. The prestige or the kind of autonomy that they had as a professional in Puerto Rico, now you're a run-of-the-mill, and you're also experiencing discrimination. This may be the first time that the professional is experiencing discrimination in their lives. In terms of housing, I remember I would bring people to get apartments, and in the phone call I had called, and they said they have the apartment ready, and when the person came in and it was darker skinned, the apartment had been rented. And so the professional undergoing that sense of discrimination and dealing with their own sense of racial and ethnic identity development absolutely impacts the work that they do with clients. So we need to I think that clinical supervision by somebody who knows these issues and can address them with the clinician is paramount, and it trickles down to the kind of service that they provide for their clients. So I would say that we need to prepare the professionals, and we need to prepare the people that are receiving them, the agencies. Like, for example, we provided in Worcester, we hired an English as a second language teacher to work with our clinicians in terms of how to write professional notes, how to give them some help so that they could come up. So some of those ideas and things that we did in Worcester.
Okay.
So I'll just stop.
Thank you, Maggie. So we're going to have Sofia Segura to talk to us a little about
my work in the
your work at the Hispanic Health Council, which is a great health organization in Hartford, Connecticut.
Yeah, hi. Good morning or good afternoon, I think, everybody. How are you? I'm Sofia Segura Perez. I work at the Hispanic Health Council. I'm the Associate Director of the Community Nutrition Unit there. The Hispanic Health Council is a non-profit organization located in Hartford, and it was founded in 1978. And the reason why it was founded was due to an unfortunate incident happening in the community. A little baby, Puerto Rican baby, died of dehydration due to diarrhea that she has. This is a very preventable death. It was a very preventable death. And the mother was, after the mother attempted to seek help for her child because she didn't got the proper care. And at that time, it was said that language barrier was the main problem for her child to get the medical care that she needed, and she died. So this brought a lot of outrage among Latinos living in Hartford, and so some activists, community activists, and medical anthropologists got together at that time and funded the Hispanic Health Council as an organization that will be starting the health needs of the Latino community, which at that time was really mostly Puerto Rican, right now continues to be mostly Puerto Rican. Like about 80%, I would say, is mostly Puerto Rican in Hartford, and 40% of the population in Hartford is Latino. So just for you to know. So that is what how our agency began. And so since the beginning, community-based research was a very important part. It really began as a research entity, and then it started providing services. But it continues to be, until now, community-based research continues to be a base for the development of services and for choosing also the best strategies to do advocacy for our community. So in 2005, in 2010, the Hispanic Health Council was part of a consortium of a Center of Health, CIROL, was called CIROL, Center for Health Disparities. It was an NIH sports center with the principal investigator was Dr. Rafael Perez Escamilla, in that time was working at UConn, and now he's working at Yale University, but has been a long partner of our agency, working very closely with us in understanding better the health disparities among affecting our population. And when we have CIROL, we approach the solution for this health disparity in different ways. So what we did was we conducted a community-based randomized study about using community health workers, which the community health worker model that the Hispanic Health Council has is not only that, the promotoras for me is a little bit simpler, like, okay, just like say, oh, you are doing well. No, the community health workers that we use is community health workers that are very involved and well trained in the area, very well trained in the area that they will be providing the services. So this study called DIALBES, it was a study that assessed the efficacy of using community health workers for diabetes with Latinos, to help Latinos manage their diabetes. So this study, the community health workers were very involved with the clinics, with a clinic, with Hartford Hospital, with the doctors and the dietitian, and they were part of the team, but were really at the Hispanic, they were working from the Hispanic Health Council. So we met weekly with the team to discuss each case. So the community health workers visit there was really did in 1 year period, did 17 visits, helping their clients to manage their diabetes, very educating them about the different aspects of diabetes management. And a very big thing was the part of nutrition, how to manage your diabetes through knowing, to reading food labels, through knowing how much a portion is. And another big thing was to understanding their medication. That was a big thing. A lot of, because we have this weekly meeting, but a lot of the clients were very confused about medication. And a lot of our clients were taking a list of 20 medications. So it was very hard for them to keep up really with all these medications. So at the end, the study found that using community health workers really decreased the hemoglobin A1C levels for 1 point. And even this change was sustained after 6 months that they were not community health workers working with the clients. So it really was, the doctors were very impressed with this. They didn't, when we did the presentation, we're very impressed, and The results have been published in a very good, well-known diabetes care journal. But it's the diabetes care journal. But what I want to say is to tell you a little bit of the things that happening when we were doing the study. The community health workers not only help them or teach them about to manage the diabetes, but also help them to empower them to find ways to better understand their medication, to prepare for their visit with the doctor, because the doctor have very few, like 15 minutes. So they teach them how to talk to them, how to tell them, how to go prepare with, this is the list of my medication that I'm taking, this is a thing that, how to do the blue glucose monitoring and everything. But also help them with transportation, help them with food access issues. There were a lot of food insecurity among the participants, meaning that they didn't have enough food to eat during some period of time. So they helped them to get food stamps or SNAP benefits. So it was they were supporting them in many ways. And a lot of the participants have grandchildren that were taking care. So one thing that we learned through this study was that a big barrier for the participants to take care of themselves was stress, life stressors. Just a lot of them have their children at jail or taking care of that small children, didn't have enough money. So life stressor was a big barrier. But in spite of that, having the community health worker with them, helping them to really manage their diabetes better. And also, community health workers were advocates for them with the doctors, with the nurses. Because the doctors don't know many things that are happening in the house and don't even think about it. Like they were like, so the community health workers help them to adjust some of the treatment. For example, some of them work during the night and sleep during the day. The doctor didn't know that. So they changed the medication so it will work better for them or for the lifestyle that they have, that they work during the night. So as a follow-up, a study that we did was with Latinos with type 2 diabetes was stress management classes that were offered. That was another study that we did. It was also a randomized study. But this was delivered also for a community health worker in a group session. There was 9 sessions that they were invited to come. And the results are that individuals who attended the more classes have better diabetes control using hemoglobin A1C. Hemoglobin A1C is a test that will tell you about what how the blood glucose control has been during the last 2 or 3 months. So we found that really the difference that community health workers did was very significant in the health for our population. And we have also conducted study using community health workers for breastfeeding support, and also found increased exclusive breastfeeding rates among those that receive the help of peer counselors, breastfeeding peer counselors. So the agency have used a lot of the community health worker model and working in partnership with the hospital and working in partnership with universities and researchers to improve to provide the services and to improve the health of the Latino community. And the last thing that we've been doing is that we go through community forums that we did with the population as a solution to decrease food deserts. Hartford is neighborhoods in Hartford are known as a food desert, and that's the lack of a big supermarket or lack of places where they can buy healthy foods. And food deserts are also characterized for a lot of fast food places, walking distance. So people don't have really many options other than going to the fast food restaurant because that's the quickest and fast. So that's a solution that the community gave us was why do through community forums and through community focus group was to bring a mobile truck in the community that brings produce, fruits and vegetables year-round that are culturally appropriate, that were culturally appropriate. So we are doing that very successfully, and people have been very happy without, it's been challenging, but they like and they can use their SNAP benefits to buy the fresh produce or week benefits to buy the fresh the produce. But what I say is that in order to reduce disparities, what we have learned is to keep the community engaged and build those strong partnerships that and continue working on that. We are also doing many other things, cross-cultural training for medical, for healthcare practitioners and social workers to make. And we are also doing. We helped to enroll a lot of people with affordable care. What I personally think there is a lot of barriers that are right now that our population that is suffering a lot of food insecurity and barriers to access to health is automatization. This is a different thing, but the automatization of all these services.
Yep.
And I've been a lot of meetings saying, but what about those that it's very difficult for them to go into and apply for food stamp online? What about for access health, which is the change that we have for getting access to healthcare? I have found they don't pay attention to that. It's like, oh no. So there is no money for agencies like our agency to help. We used to have that money, but that money has been the last 3 years gone. Gone. And nothing else has been done to try to really help individuals to enroll, to use or to enroll them into those programs. I think community-based organizations play a very important role also in the decrease of health disparities, and we are not ready to give up our communities to our community organizations because the population really needs us, although people say that we're going to disappear very soon. Probably yes, because there is no money.
Some have disappeared.
But the community really needs that help, really, because I'm all about automatization, but as long as we have also help for our community to use and to have access to that.
But thank you so much, and I want to agree with you that one of the barriers to register people into the Affordable Care Act, as some of my students who are here know from having work in a project, Todos Juntos con Seguro, is that the Affordable Care Act requires a person to have an email and to know how to use a computer. So there is
to remember your password.
And to have a password, to remember a password. So those are barriers that we found, and one of the interesting things that happened in our project was that people that we enroll in the first year were not able to re-enroll because they didn't remember the password. They forgot that we had created an email account for them, and so forth. So I do agree with that. So I wanted to say that there is sort of a common theme here. One is that you saw that a lot of these strategies that have worked in some of the projects that our panelists have worked did not require a lot of biomedical interventions to address disparities, but rather social support, information, stress management, connections, been connected with as in the case of the mothers who experience situations of abuse and domestic, or being able to manage diabetes, or to trying to lower weight loss, to get some form of weight loss that will improve the health. All these have in common that there are groups, and there are connections and social support. So I think perhaps one of the things that we need to think through is how do we integrate more social support into the kinds of activities, health-related activities that we have in our communities. I know that there is several promotoras de salud aquí, and that they are working in different fields. So that's, I think, is one lesson that we can take from this. We are about to, we're due to finish, but I wanted to give opportunity to some of you who may want to say something on topics that we didn't cover. Like I know that Dr. Falcon has worked with Puerto Ricans elders for many, many years, and I wanted to see whether he had anything to add about the Puerto Rican elders.
Well, since you put the spotlight.
And that's also true for Dr. Pares aquí. Yes, that he works, he mentioned HIV, and I wanted to know if you had anything else that you wanted to comment, and people who have different topics that we didn't cover.
I think the whole idea of social support is critical. And most of my work has been with the Asian population.
Uh-huh.
As you see changes over time.
Yeah.
And some of the things that Edwin was talking about this morning, a lot of people moving from Massachusetts to Florida.
Mm-hmm.
A lot of the older members
Yep.
of the family breaking down social ties, the older members in the family staying behind. And the question is, what do you replace those networks with?
Right.
That becomes very critical, particularly in a population that most of their ties are immediate family.
Right.
It becomes very, very, very critical to understand. The other thing is this whole thing about managing health and managing weight gain and diabetes. The fact is that Puerto Ricans on the mainland are to some extent worse off in some ways than Puerto Ricans on the island, which is a real challenge to understand, particularly when you look at other Hispanic groups. And then the other point is that we have seen, at least for the slightly more educated Puerto Ricans, an improvement in health conditions in diet as they stay longer on the mainland, which is also contrary to what we see from Mexican Americans.
Exactly.
So there are some things that are fairly complex
Yes.
about this population right there. There are some things that we can think about interventions. I mean, Josie, for example, has been doing a lot of work on thinking through about interventions and how to deal with some of these challenges that we have seen in our data. But I'll start here.
Okay.
Rather than just limited to HIV and AIDS, I would argue that I thought that this conference was going to be taking a look at what is going to happen or is happening already with the massive migration from Puerto Rico and the way it does alter our previous models in more ways than one.
Yeah.
And they need to really find ways of bringing that population in some kind of in line with the ways of the U.S. One of the great myths of the migration, recent migration, well, first of all, we know that this migration apparently is based with a lot of the so-called middle class from Puerto Rico, professional,
right,
et cetera, but a good chunk of them, and you read one or kinds of other people, are not getting the jobs they thought they would be getting, but in fact, they're in fact becoming poorer here.
Yeah, which is,
almost automatically.
yeah, look at,
So my point is that the other thing is the mythology you come from Puerto Rico. For better and for worse, even the independentistas in Puerto Rico still think that this is the land of plenty. And they also have Puerto Rico, in Puerto Rico, the specialist education about what is really the U.S. And if you take a look at short and mid long-term trends in the U.S., we're moving towards a really bad part of the neoliberal model of a big chunk of the population making just barely living wage and a tiny percentage of very wealthy. So we're going to become part of that lower end, no
Right.
matter what education you bring from the island. So I thought that
Yeah.
the HIV in particular becomes critical because not every community in the Puerto Rican, Latino, whatever you call us, is prepared to absorb and maintain the existing services and increase them to the degree that they may be needed.
Right.
And plus the issue of language becomes again a different
Right.
issue. For better and for worse, Puerto Ricans in the island are not bilingual, as the politics will say they are. They're not. And in fact, they know very little English when they come here, even the professionals.
Yeah.
And so all of those issues which were historically part of the early migration begin to play out again.
Yes.
Except this time they're coming into a shrinking economic base, even to the degree that the stepping stones of the industrial, that's gone. We're coming, plus, so we're moving into areas like Florida, which is the entertainment capital, and those are very bad jobs. So there's a specific geographic content to this. So, so my concern in terms of this panel, any panel, is that what is the diasporan or diasporican from who live here, and I think diasporican here.
Yeah,
I've been here for
that's good,
52
that's good.
years.
I like it.
How do we really deal with it? And I don't think the people here are ready for it. First of all, our current institutions are not that strong.
Right.
To start
Mhm.
with.
Mhm.
And I don't have to explain the difficulty of being Latino in Florida with the government, Republican government,
Republican.
no one to do Medicaid.
Yeah.
So the conditions are really bad.
Yeah, yeah.
So
So
that
okay.
was my
Yeah,
concern.
okay.
So the HIV is just one of the many aspects.
Many aspects. I agree. So thank you so much.
But with this panel specifically, we're talking about health disparities. I have to say that the HIV is critical, especially because in the U.S. with HIV/AIDS rates, men having sex with men is 85% of the new HIV/AIDS rates in 2013. So when we're talking about health disparities, diabetes is one, but it's mostly among young homosexual males. Heterosexual Latinos are like the 5th leading new HIV/AIDS infection rate. So
Yes, I
we
agree.
have a huge health disparity, and listening to you all on the panel, I thank you, because even having competent mental health programs, that are culturally appropriate or have those language, or having providers that, health providers that understand that a lot of these young people that are coming here now are facing homelessness, poverty, they need those increased support systems, and if you're LGBT or the transgendered women population that are out in the streets having to do sex work, those health disparities are huge, and there's very little research out there.
Yep.
So I would love to see more research on giving us light in New England. What is our percentage of even that Boricua diaspora? Holyoke's the #1 city per capita of Puerto Ricans in the U.S. at 45%, but there's no specific research just to Holyoke, because we always get grouped in with either East Hampton or Chicopee.
Yeah.
Springfield always gets all the research. But Holyoke in my city, just Holyoke, #1 city in the U.S. for Puerto Ricans, we have the dentist in Western Mass, the 4th dentist LGBT population in the U.S. But there's no studies that specifically break it down by our Latinidad or our Boricuaness to help us with our health disparities. Hugely critical, and if you have HIV, you have a higher rate for cancer or diabetes
Right.
or all these other complexities of health issues. There's no research. The agencies aren't culturally sensitive or supportive. But I just wanted to call that out to say
Okay.
that HIV is
So
critical.
it's great. Let me say that besides Dr. Luis Falcon and Dr. Milagro Rosal, Dr. Maggie O'Neill, there is also several researchers in the audience. And we should probably, you have your email,
Yes.
so you would probably connect with us, because one of the things that we didn't mention in both the work of Dr. Rosal and of Sophia is that they're both community academic partnerships, and I'm just thinking that I have recently saw that there is a call for proposals to better understand the social and cultural aspects of minorities, sexual minorities, basically, yes, sexual minorities. So there is a call for proposals, and I will I will get you that information. And as well as maybe Milagros and I and Luis and know people in our respective universities that are working on that topic that can talk to you and maybe do a community academic partnership.
And it's something that, I mean, we used to have a HIV research there, and the research right now is no longer there. But what I learned recently is, just by reading, is that one problem with Latinos and also African American is because it's where the increase of HIV is happening right now, it's also lack of access to treatment, to proper treatment, and medication.
Yes, yeah.
And medication, because right now really HIV has become a chronic disease because of the access to the medication in Africa. But not for minorities, not for Latinos, not for African American. So why not? That's I was like, no, I was thinking, why not? Why not? And you know what I felt is that we need Latinos. I'm from Mexico, and I came here when I was 25. But what I felt that Latinos were not involved enough in politics. And as an immigrant, I didn't know, but recently I was not very interested in policy. I was more interested in research, in education and research, and it's policy is not for me. But I see that we really need to understand better how the system works if we want to see and get involved on that, if we want to see that change is happening. All the meetings that I go, I'm in the Hartford Food Policy Commission. I'm in the Wellness Committee, in the Schools Wellness Committee. All the meetings that I go, representing cities where are mostly with a big percentage of like Bridgeport or Hartford, with 40% of Latinos or 40% of African Americans. Everybody, and I have a very good white friends. I'm not against it, but everybody that is in the table is only white, no? We are not there.
Yeah, that's
and they are not telling us not to be there, to tell you the truth. I'm there. But I feel that we need to be more and put more of our effort to learn more how the system, and probably put more voluntary time to do it. So that's thing that I don't know why we're not getting people with HIV that are Latino are not getting the proper medication. And it's something with the medical that is not working.
So before we leave, I'd like to get the list back. And also, you have a comment and you've been raising your hand there, so I don't.
I'm trying to say this because, yes, we're working at the individual and community level, but we need to be out there with the big social-economic impact. Like asthma, environmental issues are the biggest triggers.
Yes.
So that's what we need to work on, really. We need to get back to our political self and do something. We need to go back to, like the 60s.
Yeah, that's true.
And stuff like that, to get things done. And we need to hire more community health workers to educate the population that we're doing on that. Not just the health, because that's a little
bit,
that's just part of it.
Yeah, I agree with you. And Affordable Care Act has part of that is to include community health workers as part of the team, and it's paid. I mean, it should be well paid and everything. So that Grace Damion, who is not here, she's been working with the state in Connecticut, and including the community health workers as part of the health team, Affordable Care Act. But not all the states are doing that. So that's something that also we have to make sure.
So I think we are leaving this session, I think, with a call for action to engage in policy and to become involved and visible in whatever we do, wherever we are, and to try to continue making the case to improve the health of the Puerto Rican population in New England. Thank you so much.